Assalamu alaikum. I'm Dr. Bushra Ahmad Taimuri, Assistant Professor Neurology and Stroke Specialist in Liaquat College of Medicine and Dentistry and Darul Sehat Hospital. I, on behalf of my college and hospital, warmly welcome you all to this continuing medical event that is focused on epilepsy. It's truly an honor to have such distinguished gathering of healthcare professionals and experts in our hospital today. Epilepsy, as we all know, is a neurological disorder that affects approximately 5 million people worldwide each year, including a significant number in Pakistan, and the stats say it's about 10 individuals per 1,000 individuals. Despite its prevalence, it carries misconception and stigma, which hinders improper diagnosis and treatment. Today in this session, we will provide with the information about the proper diagnosis and treatment, and it will deepen our knowledge about epilepsy, and we will explore latest advancement and discuss ways to enhance the quality of care and support we can offer to the patient and their families. I encourage you all to participate and ask questions if needed. On behalf of my organizing committee, I extend my heartfelt gratitude to our esteemed speakers, chairperson, and participants. In this hybrid session, we have national and international speakers. I will be now listing down the names of the chairperson and the speakers. Our chairperson for today's event is Professor Dr. Ehsan Noman, who is the chairman, Department of Neurology, King Edward Medical University, Lahore. Our co-chair is Professor Dr. Abdul Malik, who is HOD Neurology in Liaquat College of Medicine and Dentistry. In our speakers, we have Dr. Asfand Khan, who is Assistant Consultant in Shifa International Hospital, Islamabad, and he will be telling us about the classification and diagnostic challenges of epilepsy. Then the next talk is of Professor Dr. Manmohan Mahendra, who is joining us from New Delhi, India, and he's the Director of Neurology in B.L. Kapoor Hospital, and he will tell us about when to treat epilepsy, evaluation and management, which is indeed a very important topic. Then we have Professor Dr. Tipu Sultan, who is the Head of Department of Neurology in Children's Hospital, Lahore, and he will be telling us about when to start anti-epileptic medications in children. Then Professor Dr. Shahid Mustafa, who is Consultant Neurologist in Asfand Hospital and also in Neurocare Hospital, Karachi, and he will be telling us about tapering and side effects of anti-epileptic drugs. Then we have the renowned Professor Dr. Fauzia Siddiqui, who is a Consultant Neurologist and Chairman Epilepsy Foundation, and she will tell us about the epilepsy care and challenges faced in Pakistan. And the last of all is Professor Dr. Mohammad Wase, who is from Asfand University Hospital. He is also President of Neurology Awareness and Research Foundation, and he will tell us about the hiccups and the solutions that are being dealt with in epilepsy in Pakistan. And I will invite Mr. Atif to come on stage and recite some verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين صدق الله العظيم.
Thank you, Mr. Atif. Now I would like to invite Dr. Malik, Professor Dr. Malik on stage to give the welcome address.
Bismillahirrahmanirrahim. On behalf of Liaquat College of Medicine and Dentistry, I welcome you all, the undergraduate and postgraduate, and as well as the respected faculty from Liaquat College of Medicine. आज का दिन इस लिहाज से बहुत अहम भी है कि ये एक ऐसी बीमारी के हवाले से है जो बहुत सारे मिथ्स, बहुत सारे स्टिग्मा का शिकार है. एंड एज ए neurologist as well as a part of the medical fraternity, that we usually not deal the patient with having the epilepsy in a proper way, that we can give them hope, we can give them a proper healthy life. So this is very important, this type of session, which in undergraduate level आप ऐसी फैकल्टी से आज लेक्चर्स सुनेंगे जो दुनिया में अपना एक मकाम रखती है. तो आप, this is part of your curriculum as well, in undergraduate level as well, and in a postgraduate level, you deal the patient. We come across with different type of seizures, uncontrolled seizure, and classify. We don't know even the classification properly. We don't know how to start the medication, how to deal with the pediatric care. So in this CME, we had all blended speakers. One from the New Delhi, he joined us, Professor Manmohan Mandaratla. He's teacher of teachers. He's a very respectable name of neurology across the South Asia as well as in the Asia-Oceania region. He's the president of the Asia-Oceania region in the stroke as well as in the epilepsy. He's a senior most neurologist who joined us for this session. Beside him, we have a speaker from Islamabad Shifa International who speak about the classification of the epilepsy, and Dr. Tipu Sultan, who is a leading pediatric neurologist in Pakistan, and also the Professor Wase, Professor Shahid Mustafa, Dr. Fawzi Siddiqui. Dr. Fawzi Siddiqui is a known epileptologist and known leading, who is the first author of the national guidelines of the epilepsy in Pakistan. So as undergraduate level, जो आपके लेक्चर्स होने हैं, मैं समझता हूं कि ये आपकी एक तरह से पूरी एक रिफ्रेशर कोर्स है. तो इसको प्लीज क्वेश्चन के एतबार से और बहुत तवज्जो के लिहाज से सुने. प्लस जो पोस्ट ग्रेजुएट हैं, जो डेली ईआर में या वार्ड में जो डील करते हैं पेशेंट्स को, तो वो क्लासिफाई कैसे करना है, हाउ टू स्टार्ट ट्रीटमेंट, ये चीज करें ताकि वी हैव अ गुड इंटरेक्टिव सेशन. सो आई वेलकम यू ऑल on behalf of LCMD and NAR Pakistan, and I also thankful to support this webinar by the Sir Pharma, so that we able to have some good interaction with the all the neurologists across Pakistan. Thank you very much.
Thank you so much, Dr. Malik. Then we will start our session now with Dr. Asfand Khan's talk, who is joining us from Shifa International Hospital, Islamabad, and he will let us know about the classification and diagnostic challenges of epilepsy in Pakistan.
Assalamu alaikum, everyone. Am I audible to the audience?
Dr. Asfand, can you hear us?
Yes, I can hear you. Can you hear me?
You are audible. You can start your presentation.
All right. Thank you. Assalamu alaikum again, everyone. I'm Dr. Asfand. I'm a neurologist and epileptologist currently working at Shifa International Hospital, Islamabad. Before I begin my talk, I'd like to thank Professor Abdul Malik as well as the organizers for providing me the opportunity to speak here. So today I'll be discussing the classification and diagnostic challenges in epilepsy. So why do we need a classification system? So epilepsy is a dynamic field with extensive research being conducted across various disciplines, including basic and clinical disciplines. And it's really important to bring all of that research together and have a standard terminology that everybody understands. Including healthcare professionals across various disciplines, as well as patients and their caretakers as well. So, for example, if you're using the term focal epilepsy with impaired awareness, it becomes immediately clear that what type of seizure the patient has, what kind of would trigger it, what the manifestations would be, what treatment is indicated, and that is very helpful in standardizing both the care as well as the research. Furthermore, it immediately tells you what the associated conditions would be, what possible triggers it could have, what the prognosis and comorbidities are. So for example, if you encounter a patient who has juvenile myoclonic epilepsy, you'll immediately understand that, they would have myoclonic jerks, particularly worse early in the morning, and then they would probably require lifelong treatment, and that they might have some sort of psychiatric comorbidities as well. So it gives you a lot more information, and this is just packed into a single category instead of having a detailed note which communicates all of this. And then seizure classification also helps you decide what sort of treatment to give the patient. So if somebody has a focal to bilateral tonic-clonic seizure, we know that the preferred drug would be a sodium channel blocker, which could be carbamazepine or oxcarbazepine, and that helps you out in selecting the treatments. So keeping all of this in mind, the International League Against Epilepsy has classified the seizure types as well as the epilepsy types and epilepsy syndromes back in 2017. And this is the first classification we've had since 1989. And in between, we had a couple of position papers from ILAE, but this is the first classification that was completely endorsed. And it basically classifies any paroxysmal event that we see in a patient, which we suspect to be a seizure, into 3 levels. So first, we classify it into the seizure type. And then if those events meet the criteria of epilepsy, the diagnostic criteria of epilepsy, then we would classify the epilepsy type and then try and reach an epilepsy syndrome. And then we'll go through each of them step by step. But at all 3 steps, we need to focus on the etiology as well as the comorbidities. Because again, it would give more information, it would help you in selecting the best treatment, and it would help you in reaching the epilepsy syndrome as well. So we'll start at the first level, and even before this, you need to be sure that this is a seizure. Whatever paroxysmal event you've encountered is a seizure. If you're sure that it's a seizure, you move on to level 1, and level 1 is the seizure type. So the seizure type classification that ILAE has published has 2 versions. One is the basic version that we can see on the screen here, and then on the next screen we'll be seeing the advanced version or the expanded version. And the basic version is for use for all healthcare professionals who aren't trained neurologists or epileptologists. And this one has been prepared just so it is easily communicated to the patients as well as their caregivers. So it's a very simplified version. So we start from here. We see the first category of focal onset, then generalized onset, then unknown onset, and then there's a whole separate category of unclassified. So when you're looking at this slide, the thing you need to focus on is that we're basically trying to answer 3 separate questions. So the first question is whether the onset is from one part of the brain or both hemispheres of the brain. So if the onset is from one part of the brain, we label it as being a focal onset seizure. And if it involves both hemispheres of the brain, not necessarily the entire brain, or not all parts of the brain are have to be involved mandatorily, but just both hemispheres of the brain. If both hemispheres are involved, it would be a generalized onset seizure. And then unknown onset would be any patient having a seizure whose onset was not witnessed. So think about any patient who was asleep when they had a seizure, or who was drowsy or unconscious for whatever reason, who was under the influence of drugs and couldn't possibly recall the seizure and was unwitnessed. So the first question was whether it is focal onset or generalized onset. And the next question is whether or not the patient was aware of himself and his surroundings. So if the patient was aware of himself and his surroundings, we would categorize this patient as being aware. And if they weren't aware of themselves and their surroundings, we'll categorize them as having impaired awareness. And then the third step the third question that we need to answer is the degree of motor manifestations we see in the patient. So if there's no motor manifestation, we would be categorizing the patient as having a non-motor onset. But if there is any sort of motor manifestation, the patient would have a motor onset. And if it starts from one part of the body, then spreads to both sides, then that would be labeled as focal to bilateral tonic-clonic. The important word to focus on this slide is the word onset. So we're looking at the first manifestation that the patient had during the seizure. So we don't really need to know what happened after the initial manifestation. So if somebody had a non-motor onset and subsequently developed a motor manifestation, for example, jerking of the limb, then we wouldn't really consider the subsequent manifestation while classifying the seizure type. We're only interested in what the first manifestation was. And the only exception to this rule is the awareness. We consider awareness being lost if at any point the patient loses awareness. So if there's even a loss of awareness 2 minutes down into the seizure, we'll still consider the patient as having impaired awareness. So for focal onset, we have three different categories. So the first is either with intact awareness or with impaired awareness. The other category is either motor onset, non-motor onset, and the third category is something that started focal and then went on to being bilateral tonic-clonic, which was previously called as being secondarily generalized. With generalized onset seizures, we again have two main categories. One is the motor onset and the other is the non-motor onset. So for motor onset is anybody having any sort of motor manifestations in their limbs. And with non-motor onset, we're typically thinking about absence seizures. Again, there's an exception that some patients with absence seizures can have some minor motor manifestations, so they can have some eyelid myoclonia or some lip smacking as well, but those would be atypical absences and not the typical absences. And then for unknown onset, anybody who was asleep or intoxicated or drowsy or unwitnessed would be placed in the unknown onset category. And for the unclassified patients, those are the patients who had a seizure. You know for sure they've had a seizure, but you're unable to classify the patient because of a lack of complete information. But the onset was witnessed. So if the onset wasn't witnessed, it would be unknown onset. So this is the expanded version of the same thing. This is the same thing, but with more details. So this is the focal onset seizure, awareness intact, impaired awareness, and then these are the motor onset seizures, and these are the non-motor onset seizures. So those of you who were familiar with the 1989 classification would remember that this was previously called, the focal seizures were previously called partial seizures, and a lot of you would probably hear this terminology even going further. But it's really important to use the newer terminology, but at the same time realize how the previous terminology has translated into the newer terminology. Because again, our focus is to ensure that the terminology is standardized and understood across the board. So this was previously called partial onset seizures, and then focal onset seizures with awareness were called simple partial seizures, and those with impaired awareness were called complex partial seizures. And then we talk about the further classification, which would be motor onset and non-motor onset. And then motor onset is typically automatisms. So a sort of a series of involuntary actions that happen, and they're stereotypical, always happen at the onset of seizures. Atonic, just meaning that there's a loss of tone in the limb or the body going limb. Clonic would have repeated jerks. Epileptic spasms is a relatively newer terminology for infantile spasms, which were previously only thought to be generalized in onset, but have now also been included in the focal onset. And then they're also here in the generalized onset. Hyperkinetic seizures would involve rapid, aggressive jerking of the limbs. Myoclonic would be a single or a cluster of a series of rapid, the fastest activity, the fastest muscle contraction that you can imagine. And then tonic would be an increase in tone. In terms of non-motor onset, there could be autonomic symptoms. So any sort of autonomic activity, you could have goosebumps or tachycardia, changes in blood pressure, changes in vision, including blurring of vision. Then we could have behavioral arrests, which are very similar to absences, but different in a lot of other ways as well. And cognitive seizures, so typically they would involve deja vu phenomena or any déjà vu phenomena, feeling that you've experienced this thing before, or feeling that something that you've already experienced before has not happened, so failure to recall a previous event. And then emotional seizures, in which they could again get a sort of anxiety attack, panic attack, getting really episodes of crying or anger outbursts. And then sensory seizures, which could be pain, paresthesias, something like that. And I would really want you to focus on the sensory non-motor onset seizures and remember the outdated terminology of aura that we used to hear. So what exactly was aura? It was the first manifestation of a seizure that was non-motor in onset and focal, in which the patient had intact awareness. So this is where the term of aura has been adjusted in this classification. So, how we used to categorize aura, the most common aura was a rising epigastric sensation, but now we know that this is in fact a focal onset seizure in which the awareness is intact and it is of non-motor onset. So, auras have been classified here. And then focal to bilateral tonic-clonic we've already discussed, and generalized onset, it is pretty much the same as focal onset, but again, depending on the distribution in the body. So you could have tonic-clonic, which means that there would be an increase in tone followed by clonic movements. Clonic alone, tonic alone, myoclonic alone, myoclonic, tonic, clonic in this sequence, or myoclonic, atonic. So they'd have a jerk and then they lose their tone in the body. And then atonic and epileptic spasms. So note how epileptic spasms have been added here as well as here. So they could be focal onset or generalized onset, just slightly different from the previous categorization. And then we've got non-motor generalized onset seizures, which is another term for absence seizures. So absences could be typical, atypical, myoclonic absences, or eyelid absences with eyelid myoclonia. And typical absence is anybody having a very brief, rapid onset, behavioral arrest with no loss of postural tone, and who recovers quickly, having multiple episodes a day. And anybody who doesn't meet this criteria is typically has an atypical absence. And then you've got an EEG criteria as well of certain, frequency, and that isn't really related to the classification as now. So then we have everybody who has an unknown onset. So anybody who had a seizure in sleep or was unwitnessed and had impaired awareness. So we really don't know how it started. But so think about a patient who was found unconscious and seizing at that time. So that patient can only be categorized as having a motor or non-motor onset, but the actual onset is unknown. We know that it has a motor onset, but not exactly whether it was focal initially and then focal to bilateral tonic-clonic, or whether it was generalized onset. And unclassified we've already discussed. So now that we're done with level 1, we move on to level 2, and level 2 is basically epilepsy types. So anybody who has a seizure type of focal, so you've categorized them, or a patient having only focal seizures, that patient would be categorized in focal epilepsy. Anybody who has generalized seizures would be categorized in generalized epilepsy. And any patient who has focal seizures as well as generalized seizures would have combined generalized and focal epilepsy. So think about Dravet syndrome, LGS. Those are the patients we would be categorizing in combined generalized and focal epilepsy. And then we have an unknown epilepsy type for patients who have unknown seizure types. Before we move on further, I'd just like to point out that focal epilepsy could have unifocal seizures or multifocal seizures. So anybody who's always having focal seizures, but the foci arise from different areas in the brain. So sometimes they have a focus arising from right temporal or at another time. And then when you look here, you can see that comorbidities and then the etiology actually runs in all 3 levels. So at all 3 levels, we're focusing on classifying on identifying the comorbidities as well as the etiologies. So what exactly is the etiology? So anybody who's had a seizure but still doesn't meet the criteria of epilepsy or an epilepsy syndrome still needs to be have assigned an etiology. So structural etiology would be, for example, anybody with a tumor, an abscess, a previous stroke or a bleed, an AVM, anybody having a structural problem in the brain. And anybody having a genetic etiology would be somebody who has either a chromosomal or a genetic defect leading to their epilepsy. And the, again, outdated term of idiopathic generalized epilepsy. So idiopathic is still used in this classification, but the classical term idiopathic generalized epilepsy has been changed to genetic epilepsy. Genetic epilepsy from the etiology, and then generalized epilepsy from the epilepsy type, and the seizure type would be generalized as well. So anybody who doesn't have an identified genetic defect but has a presumed genetic defect, so somebody who doesn't undergo a genetic test would still be labeled as having a genetic etiology. For infectious etiology, think about patients with encephalitis, HSV encephalitis, cerebral malaria, toxoplasmosis, neurocysticercosis, anybody having a problem, an infectious disease in the brain. But then also remember that one patient could have multiple etiologies or they could have no known etiology. So somebody with a neurocysticercosis will have an infectious etiology, but then they also have a structural problem. They have those little neurocysticerca lying in the brain. So it's a structural problem as well. So somebody could have both, two or more etiologies. And then with metabolic epilepsies, think about glucose transporter 1 deficiency, cerebral folate deficiencies, polinase problems, pyruvate kinase problems, mitochondrial disorders, everything that we used to cover in biochemistry. And then we have a separate category for immune epilepsies. And this could be with encephalitis. So think about NMDA receptor encephalitis, LGI1 encephalitis, or it could be without an encephalitis, just in the entire category of immune epilepsies that we're increasingly seeing recently. And these are patients who don't have other problems, just epilepsy. And then unknown would be anybody who doesn't have any of the aforementioned etiological categories. So next we move on to an epilepsy syndrome. So before we categorize an epilepsy syndrome, what is an epilepsy syndrome and why do we need to classify it? So going from this side to this side, we see that this is somebody without an epilepsy syndrome and this is somebody with an epilepsy syndrome. So an epilepsy syndrome is a constellation of electrical and clinical features. So anybody with a particular type of epilepsy with a typical characteristic seizure, one or more types, who has a typical EEG characteristics would be having an epilepsy syndrome. So think about JME, for example. So juvenile myoclonic epilepsy, we know they'll have myoclonic seizures as well as generalized seizures, generalized tonic-clonic seizures and absences. And then we have a typical EEG manifestations of it. We know we'll see it and we'll recognize the spike and wave characteristics on EEG. And it's an epilepsy syndrome because we know the prognosis. These patients are relatively well controlled on medications, but do require lifelong medication. And then we know that there are specific comorbidities it is associated with. Mood disorders, psychiatric comorbidities, and there is a unique etiology. Same goes for example, Lennox-Gastaut syndrome. It has a poor prognosis. It is associated with cognitive decline, learning disabilities, dyslexias, mood disorders, behavior problems, and then it has a specific etiology. It could be due to birth-related trauma, major CNS infections, asphyxia, and things like those. So in terms of epilepsy syndrome, this is how we classify them. So these are the generalized Yes.
Can you hear me? We are a little short of time. I'm very sorry to interrupt. You have 2 to 3 minutes more for this.
Okay. I'll just wind up.
Thank you so much.
So these are okay. So these are how this is how we classify the epilepsy syndrome. So this is a focal epilepsy syndrome classification. So once you've identified a focal epilepsy syndrome, we would classify it according to the age of onset. And so the common ones would be mesial temporal lobe epilepsy with hippocampal sclerosis. It will give rise to a focal epilepsy syndrome, and its onset would be somewhere around childhood to adulthood. This is how you would classify a generalized epilepsy syndrome. And again, this would be juvenile myoclonic epilepsy starting somewhere around childhood and from adulthood. And similarly, these are generalized and focal epilepsy syndromes. Again, this would be epilepsy with reading on induced seizures. It would have both focal seizures as well as generalized seizures and starting in adulthood. So this is a whole different classification, which I've not gone into, and this is for epileptic encephalopathies and developmental encephalopathies. And it's considered entirely separate from the previous classification, and it would have the common ones as progressive myoclonic epilepsy, Rasmussen syndrome. Most of these patients are either neonates or children, but some of them go up to adulthood in terms of age of onset. So, in terms of diagnostic challenges, we're short of time, and I'll only focus on one diagnostic challenge, and that is using our clinical history taking skills or to determine the seizure frequency. And I would highlight this recent review article. It's not really recent, but published around 6 years back in Lancet Neurology. And compared to patient self-evaluation, objective evaluation by video EEG monitoring or long-term ambulatory EEG monitoring revealed that patients document fewer than 50% of their seizures. So a major diagnostic challenge in epilepsy is that when you ask somebody how many seizures they've had and you only have information coming from the history, the patient would be telling you less than 50% of their seizures. So if they're reporting 5 seizures, you should be thinking a number around 10 or even more. And that's a huge challenge in our resource limited settings where video EEG and prolonged long-term EEG monitoring, as well as limited availability of mobile phones with cameras, affect our ability to get objective evidence of seizures. This is pretty much it. The time was limited, so we had to rush through things. But the take-home message from this is that we need to use these updated terminologies even when we're talking in the informal settings, because a lot of the times I hear people still using the terms complex partial epilepsies, simple partial seizures, and when you continue to use these, there is going to be a huge time lag between the current research and the way we're